Hey everybody, welcome back to the ECG channel. My name is Reid, and don't forget to download the PDF down in the description of today's ECG, and feel free to like this video and subscribe to the channel if you enjoy the content and the reviews. So let's jump into it. So I like to start off by looking at the forest, just getting an idea of what's going on, and so maybe I'll come down here to V5. First thing I find when I look at this rhythm is that I've got a wide complex QRS that appears to be very regular. You can see these wide complex QRSs kind of look a little bizarre, but that's all right. We have an approach to these things, and so you kind of scan through and you see the pattern stays the same. All right, so let's talk a little bit about what we can start noting. So one, it's got a wide rhythm. Okay, so working through what causes wide QRS complexes. Why is it not taking the His-Purkinje system? Okay, well, if we take a look at the rate of this, we've got a QRS here that starts on a solid line. So maybe we'll go here 300, 150, 100. This is 75, so somewhere in between 100 and 75, we'll call it, I don't know, 85 beats per minute, right? Close enough. I'm happy with it. So we've got a wide complex rhythm with a normal rate. Okay, so this could be either a ventricular rhythm, this could be a normal type of sinus rhythm with an aberrancy, right? So kind of working through that. And I look through, just generally speaking, I see I've got nice P's in front of my QRSs, right? You can look up here. Here's my P waves, right? And here's my T waves, right? Starting to kind of work through. So maybe this is coming from above. Maybe this is an aberrant conduction, right? Let's start to work through it. So those P waves that we identified, if we look up here in lead 1, they are upright. And if we look in AVF, they are also upright. It tells me that they're going down and to the left, which is likely a sinus P wave, which makes sense. Sinus node usually beats in between 60 and 100 beats per minute. We've got an 85 beat per minute rate, so things are adding up. Okay. Next thing that needs to happen is the AV node needs to grab onto that P wave and send it down to the QRS, which takes 120 to 200 milliseconds, which is our PR interval normally. So let's take a look at our PR interval here. Maybe I'll choose, let's see, this QRS kind of starts right on just about at a solid line, just before that solid line. And you can see the P wave here begins over 5 little boxes. I'd say that's probably 7 little boxes. Its PR interval is 7 millimeters. So that means my PR interval is 7 millimeters times 40, which is the amount of milliseconds per millimeter. So that's 280 milliseconds, which is too high, right? 200 is the upper limit of normal. So we have what we notice is some type of AV block. It's our job to determine, is this a first, second, or third degree block? Well, does every P wave conduct to a QRS? So far, it appears to be that way, right? I see P wave, QRS, P wave, QRS. I don't see any extra P waves, right? And this is no dropped beats. As I scan through this entire rhythm, I don't see any dropped beats. So because of that, we can call this a first degree AV block, right? Let me write that a little better. We've got a first degree AV block, right? We're just taking a little longer for the AV node to do its thing. Alrighty, so now let's evaluate the QRS complex. We said it's a wide rhythm. Well, let's kind of quantify it. Maybe we'll go out here and we'll measure the width of our QRS. It looks to be about maybe 3.5 little boxes, which we know every little box is 40 milliseconds. So our QRS duration is, do that math, 140 milliseconds, which is also a little bit too long, right? We want it to be at least under 120 milliseconds. So something is causing the conduction when the AV node takes it and decides to send it down. It's not taking that His-Purkinje system because it's taking too long. So that leads me to think, what type of bundle branch block might we be seeing? In which you notice, I think all of you guys probably picked up on a little earlier than we have, is when I look in the lateral leads V5 and V6, you see I've got this R prime type of thing, R prime, right? And that's an R prime, is that second upward deflection. And when you have those in the lateral leads, right, you can even see it here in lead 1, which is one of our other lateral leads, right, little R prime. That tells me that there are late forces heading towards my lateral leads. Well, that happens in the setting when the right bundle branch is, when the left bundle branch is blocked. Sometimes, you just got to drink a little more caffeine. I think that's the trick. But regardless, When your left bundle branch is blocked, conduction goes quickly through the right ventricle, depolarizing that territory rapidly, and then you get cell-to-cell slow conduction as it's going from gap junction to gap junction, and that's not as efficient as our His-Purkinje system. So you get late forces that are going where? Towards the lateral lead, so you get as R prime. So that's a left bundle branch block morphology. You also see we lose the septal R wave, right? We have no septal R wave. Well, what does that even mean? Well, remember that the left bundle, I look here on my transverse axis, the left bundle supplies these little fibers that will initially, the first thing that happens is we have depolarization off the left bundle of our interventricular septum, and that is going towards V1. So V1 usually has a little R wave before you go to the S wave. But in a left bundle branch block, what do we have? We have loss of that R wave because the left bundle is blocked and all this conduction doesn't occur. Pretty cool. So we have a left bundle branch block. We have a lot of evidence for that. Alrighty. Now let's look at our QT interval. Right, our QT interval, I like to sometimes I'll just take an interval between two QRS complexes, kind of measure that midway point, and it looks like my T wave kind of ends by that point. So I think my QT is okay. I'm happy with that. All right. Now I need to look for pathological Q waves or ST or T wave changes. I don't see any pathological Q waves, right? ST and T wave in this case is best evaluated using a different criteria, Scarbosa criteria, because we know whenever you have aberrant conduction, such as seen in a left bundle branch block, you're going to have aberrant changes to your repolarization, or the ST and T waves, right? That represents the ventricles repolarizing or recovering. And so this is a good criteria to look up and study if you want to get better at understanding ischemic changes in the setting of a left bundle branch block. But luckily here we don't have any. And so we can put this all together. We have a sinus rhythm at 85 beats per minute. We have also first degree AV block with a PR interval, slightly elevated at 280 milliseconds, and a left bundle branch block. So hope this helps you understand, the physiology and the anatomy of the electrical conduction system. We have a couple of areas of concern with this ECG, right? This person's got disease at their AV node. They've got disease in their left bundle. All right, so sometimes you want to work these patients up. Do they have ischemic heart disease? What are their chronic risk factors? Why has there been so much wear and tear on the heart? What has happened, right? And so I think these are great questions to ask yourself clinically when the patient's in front of you, based off of your interpretation of the anatomical lesions that are kind of seen in this ECG. So I hope that helps. If you have any questions, throw them down in the comments, and if not, thank you so much for watching. Have a great rest of your day. See you at the next ECG video.